Okay, guys. So we'll make a start with the session. So what we're looking at this week is essentially objective measures and sort of equipment available to us to help kind of quantify certain things, be it movement, be it muscle strength, which is going to help us ultimately as physiotherapists to try and sort of help ascertain whether any progression has occurred. So ultimately, what we're looking at for this short session really is for you to have an understanding of the methods available to you, how they objectively measure certain parameters, and ultimately, as with anything that we like to do, is for you to apply them to a particular case. Because that's what we want. We want you to understand, yes, what they do and how they can be used, but then apply it to a case to try and help that reinforce that understanding. So these are the kind of the things that we're going to look at, what we would call patient-based parameters, and the equipment available to us. Okay, and we ultimately want to try and use as much objective equipment available to us because it's a much more reliable way of ascertaining progression. Rather than just trying to eyeball everything, it can be really quite useful for you as a practitioner to ascertain any progression, but perhaps more importantly to the patient as well, so they can actually see the improvements they are making under your care. So we look at the first one, the range of motion, and again, some of you may have come across this before, but there's a way of measuring joint angles known as goniometry, and when you guys go on placement, you will see this in use a lot more. Very, very, very common indeed. And we have some on campus as well. And basically, they're used to measure joint angles in a passive range of motion. We tend to use them in a passive because ultimately when we're using passive motion, we're looking for end feel, so we can, like you've done in your practicals, what we talked about is taking someone to that end feel, and that's why it's done in a passive range. So we're really measuring kind of maximal terminal range. There are different ones out there. There are three sort of types of goniometry out there. You've got your standard goniometer, which is the equipment in the middle, which is by far the most common, where essentially we use each arm across the joint that we're going to measure. We identify certain bony landmarks and align those arms up and measure the angle in between them. We have electrogoniometers, which are less common, which you can see in the bottom left there. They use electrodes, so it's supposedly more accurate. Again, they're less common in practice, potentially more common in sort of research-based fields. But again, exact same kind of principle really. And the third one is what's called an inclinometer, or you might see them called bubble goniometers, things like that, which essentially they look for more the angle of a slope really. So they tend to be a little bit, I've tended to see them using when looking at say lower back ranges of movement, rather than sort of any of the other goniometers, just because of the length of the axis. And how's it done? It's very, very straightforward, really. You're moving the joint to the end of range of motion, and that's obviously why we're quite big on it in terms of when we were teaching about those passive ranges of movement. You've got to determine the end feel, and thus you're measuring kind of terminal movement, which is ultimately what we're looking at. And you do that by identifying and palpate certain bony landmarks, which again, you did a lot in your practicals, and we will continue to do that throughout the module, really. And again, you're just aligning the arms on a standard goniometer or the electrodes on a electrogoniometer to kind of essentially get your axis point, and ultimately it's the angle, the difference in between the two axis points there. In terms of muscle strength, there's quite a number of things available to us. I know one of the things you did in your anatomy practicals, those that you've done them already, those of you that will do them later on in the year. It's a very, very subjective scale. It runs from 1 to 5, 5 being the strongest. It is the most widely accepted scale that's out there, so it is used quite a lot. And it can be used in a number of different ways. It can be used to sort of identify any potential weakness, which will lead to increased risk of certain illnesses or injuries, say, like I've put on there, falls or certain biomechanical issues. Again, probably more commonly, we would use them to assess progress after illness or post-surgery, when muscle strength really will be affected in some respect. And again, apologies for those of you that have already done this, but you can see there it runs from 1 to 5 there, essentially with the use of gravity as a frame of reference, and obviously number 5, which has been left off there for some reason, will be kind of full muscle power basically, and that obviously gives you the derivative there. So it is widely accepted. There are certain limitations to it, guys, and it's something that you may find practitioners don't use. It's something I rarely use purely because I'm from an MSK background, and I think that because of its subjectivity, it's quite difficult to make sure that you're saying a 4 out of 5 is a 4 out of 5. Someone might call your 4 out of 5 a 3 out of 5, if you see what I mean, which is what's been related to there in terms of intra-rater reliability. They're not very functional because ultimately, because it is you that's doing the actual resistance, then you have to position a patient in a particular way, like we did with our resisted movements in the practical sessions. And they're not really particularly functional because they'll often be, well, they'll always be non-weight bearing, and that doesn't really give you an indication of the kind of the muscle performance during movement. And it's very difficult to say, make sure that the difference between a 3 and a 4 and a 4 and a 5 is equal. So it's not particularly useful for that. And ultimately, we can only ever assess it in terms of a concentric muscle performance, muscle movement. And ultimately, as therapists, we typically want to see and try and assess other forms or other types of muscle contraction. So one of the things that comes out is something called dynamometry, and there's a couple of types of that which I'll go through. Handheld dynamometers are becoming more and more useful now. You tend to see like the one here in the particular picture in the bottom right, where it's a handheld device and you're getting the patient to resist against that device, and it essentially quantifies the muscle power that's been produced there, which is really quite useful. They give you instant results. You can do it in a wide variety of joint movement, so it doesn't have to be necessarily in 0 degrees flexion, anything like that. So they actually can be quite useful, and because of their portable use as well and their instant results, they're really quite handy. The only downside to them is ultimately it does rely upon your actual strength as a practitioner. So, if you can become overpowered, it's very difficult to then isolate that particular movement. But again, they're starting to creep their way in. Another specialist version of this is you can find dynamometers now to assess grip strength, which is quite an important marker in terms of upper limb function. And grip strength has been sort of related to more and more now, and is often seen as a risk factor for developing certain upper limb injuries now. So again, it's the same type of principle if you do see the kind of the grip strength, but they're really quite nice to use because of their, yes, there are particular limitations with it, but because of their ease of use and their instant results and objective results, they are really quite useful as well. And kind of the step up really from your handheld dynamometer is what's called isokinetic dynamometry, or IKD, as some of you may have heard of it as. The beauty of this is that you can assess the strength of a muscle throughout the range of a particular joint. And then therefore you're assessing kind of inner range, mid-range and outer range, and seeing whether there is any differences in that particular range. The beauty of it as well, it will essentially measure opposing muscle groups during the same movement. And that can be really quite indicative of developing particular injuries. So the best example, and as we can see, is set up in the bottom right in the picture, is that we're set up for kind of knee extension and flexion. So what the isokinetic dynamometer is assessing there is the strength of the quadriceps against the hamstrings. And if you go on to look at this in a bit more detail, or if you go and work in things like elite sport, they're often reported as a ratio. So in terms of quad, so it's hamstring strength towards quads. So it's called the hamstring quads ratio. And typically within an elite sports setting, they'll look at 0.7. So hamstrings are 70% as strong as the quads. Anything out of that, it could be an indicator of developing a knee injury. Because essentially, if you've got really strong dominant set of quads that are going to really force the knee extension, you need that kind of eccentric hamstring strength to control and decelerate that movement. Otherwise, as I say, you do become quite high risk of developing knee pain. And with that, it can provide injury risk. So certainly a lot of the testing that I've done over the years, IKD are used on elite sports performers. I mean, the beauty of it as well is, I mean, it's set up for a knee there. You can use it on a hip, an ankle. In your grappling-based sports, so a lot of the rugby league guys tend to do the two rotations, external to internal, because of the grappling nature of it, and looking at or trying to identify the risk of players developing shoulder injury. So really useful bit of kit. Again, the massive downside of them is that it's not particularly portable unless you are the world's strongest man. But again, they do provide instant results. And again, it's very, very reliable. It gives you objective data. So you do have a frame of reference. So if you wanted to do it early on in someone's rehabilitation and 6-7 weeks down the line, it really gives you an idea whether your particular exercise regime is having an impact. And it's really useful, again, for the patient to have that objective data. You will find with in the IKD as well, it can be done at various speeds. So the slower speed is used to assess peak muscle force, so the maximum amount of force that a muscle can do, and the actual arm will move a lot slower, about 60 degrees a second. And you can then use it in terms of where the arm moves really fast. So that can be used essentially to look at how a muscle fatigues. So if you're looking at, say, for instance, the peak muscle force, we would get them to do it to get the athletes or the patient to maybe do 3. So 3 extensions, 3 flexions as hard as they possibly can. Obviously, the arm, the harder you push, the harder the arm pushes back. So it is a maximal effort. The quicker speed, which is usually 120 degrees a second, we would get them to do it between 15 and 20. So it's as hard and as fast as they can move the arm. So you can see how the quads and the hamstrings in this instance would fatigue between kind of set 1 and set 15. And that's really vital information. That's something that you can't do on your own. It's very unreliable to do if you had it with a handheld dynamometer. and again can give you an indication of where your rehabilitation needs to focus. So, you know, if there is a difference on the quicker speeds, then it might be that you have to set more endurance-based sets and reps in your exercise regime to try and tackle that. But as wonderful as it is, of course, it's never perfect. And similar with a lot of these aspects that we will discuss is that the functionality of them. As you can see from the diagram below, you are fixed, you're in a sat up position, extending your knee, which you know you could argue is not a particularly functional movement, and there wouldn't be many very occasions during the day that you would do that particular movement. And of course, it's non-weight bearing, so it doesn't necessarily give us an indication of how muscle force is affected through the effect of gravity or through weight bearing. So they're the muscle strengths. We've had range of motion and muscle strength, which are, you know, are quite controlled, usually done in a single plane. So now we need to look at, well, how could we possibly measure things in a more dynamic, multiplanar kind of movement? And there's a few things that we can use to do that. The first thing is called a Kistler force plate, which you guys may have come across, becoming very, very popular now. And there's lots and lots of things we can do with this. It can be used to assess the quantity and the quality of movement. Again, the more recent uses of it is becoming towards the latter in terms of the quality of movement. And it's done sometimes in conjunction with electromyography, which I'll come on to in a little while. In a nutshell, what does it do? Well, it analyzes an individual's ground reaction force and generates certain data off that. And that can be really quite useful. Again, you'll see them use multiple in multiple settings. Elite Sport for one. Podiatry use it a lot to assess gait. So obviously, when the patient is kind of walks onto the force plate, you can see the characteristics from the heel and the toe off, and how that weight is distributed across the foot. So that's really quite a nice one to do. It could be something that could be used to assess somebody after a neurological illness or during a neurological illness, to have a look at that. In Elite Sport, you will look at it to assess how an athlete develops things like power. So one of the most common things that it's used to is assess jump height and jump performance. And it can do that by using the ground reaction force to time on the way down, the eccentric time and then the concentric time, and that can be really useful information as well. It has been used to assess balance, so to try and give a quantitative and objective assessment of balance by looking at what's called time to stabilization. So it might be that you get someone to either do a single leg stand, like the chappie in the background of the diagram, and what it will do on the weight bearing leg, it will look at the medial lateral sway of the foot and calculate the time it takes to return to what's called stable. So it is reported in terms of time rather than any kind of measurement data. But again, it's objective and it can be used. It's a frame of reference. So again, it's quite easy to see some form of improvement. So really quite useful in that respect. They're very portable now. I mean, back in the day, these used to be based in the floor of a laboratory, and you had to get people to come in. But the beauty of them now is that the vast majority are portable, so you can take them to the side of a pitch or in a gym, on a court, wherever. You could take them anywhere, and they're really quite useful in terms of that. And as we said at the bottom there, again, you know, we almost start to profile now to make things a little bit easier and assess where the deficit may be in whether it is looking at jump performance or gait or things like that. So it helps to kind of profile your patient and then, you know, do your rehabilitation and your exercise therapy accordingly. So really quite useful and quite readily, widely used now. And we have one at the university, which we would get you to use, but such is the way of the world at the minute, that's not necessarily possible. And going on the theme of balance, that you have the Star Excursion balance test. Again, many of you will come across this before, I'm sure. It's actually, despite its simplicity, it's actually proven to be really quite reliable. Again, it's been mainly used now to profile patients, and what I mean by that is they profile the movements which could lead or put you at high risk to particular injuries. So things like anterior cruciate ligament injury and things like that. So you can see that there's eight different directions. Essentially the points of the compass, and then the kind of the diagonal, and you will do it by performing a lunge and measuring how far you can put your other leg, your non-weight bearing leg, out whilst remaining stable. This is a little bit more functional, again going down the functional aspects, because it does put your obviously the testing leg is the one that's standing, and it does put that lower limb into lots of different positions, and positions whereby non-contact injuries typically happen. So it is mainly used again in kind of a sport environment. There is a more simplistic version of it called the Y test, or the Y balance test, which is on the right hand side, which as you can see, they're not been particularly creative with the name of the test, and it's 3 points, but again really proven to be quite reliable. This can be easily set up, guys. I mean, you can have as we can see on the bottom right, you can actually have equipment, or you can just put tape on the floor and you simply mark on the tape and use a tape measure. So really quite nice, portable and easy to set up test to use. And again, because of the measurement being in centimeters, it's really quite straightforward to see if there's been any progression or not. And what I quite like about this is if you identify a particular direction in which the patient is lacking, then you can essentially set an exercise based on it. The movements on this are essentially exercising themselves, so it's really quite a nice simple one to use. And finally, electromyography, and again, this is something that I'm quite interested in, and I intend to use certainly in my research over the next couple of years, to look at muscle activity. Now, the downside straight away is it can only identify superficial muscles, which are mainly your mobilizers, the ones that are responsible for developing sort of peak forces. So in terms of they're used to objectively measure deep stabilizing muscles is debatable. But for superficial muscles, really useful indeed. Again, tends to be used on opposing muscle groups, as you can see from the two diagrams that we have on the right hand side, quads and hamstrings and biceps and triceps. And essentially it will measure the activation of those muscles throughout the movement. So now we're starting to think about more quality of movement. Yes, we measure it quantitatively, of course we are, with it being an EMG, but ultimately it's about, well, when do those particular muscles start to activate? Okay, so actually the range is almost irrelevant to a certain aspect, and we're looking at what we would call neuromuscular strategies employed during movement. So really quite nice to use in terms of, I've used it before when I've been getting athletes back from long-term injury, and to see how they produce the movement from one side to the other. Yeah, because we want it as close as we possibly can, otherwise you increase the risk of injury. There's research coming out, and it's not something I'm over familiar with, bearing in mind I'm massively MSK based, but suggests presence of neurological conditions, and to look at, again, whether certain muscles are firing or whether they remain quite dormant. So really useful bit of kit. These are improving all the time, and you can get the more recent ones now are things like accelerometers in it as well, so it can tell you actually the rate of acceleration of a joint and deceleration, things like that, which is really quite useful for advanced sort of analysis, really. But as you can see, really portable. The vast majority are wireless now. You don't get many wired ones coming out, so you can use them and get your patient to do lots of functional movement. So whether you are assessing a runner who only gets pain after 6 miles, you know, it's something that you can put someone on a treadmill, for example, and they can run, and you know the EMG will calculate the muscle activity, so you can actually see when certain muscle starts fatigue. So really quite useful. And again, just adding clinical reason, and we come across that term, don't we? And we've mentioned it already, clinical reason, and we're going to bore you to death with that term, but it's reasoning, and it's justifying and reinforcing and supporting your reasoning for a patient having particular symptoms, because not all injuries are very easy to diagnose, and we'll teach you about that in year 2. But again, it's having these at your fingertips that you could use clinically to help diagnose, but also what's nice about them is to ascertain the progression of your patient. And that's really quite important, because it essentially it clarifies that your exercise regime or your treatment regime is working, be it strength, be it function, be it range, but also to have that ability to tell that to the patient as well and say you've improved by X number of centimeters or Y number of degrees, or you know, you're able to remain balanced for Z more seconds, things like that. So really quite helpful. The case studies, guys, they are on a separate file, and I want you to, it's all self-explanatory, but think about the equipment that you can use in those case studies. Think about what you would be measuring. I don't want you just to necessarily list the equipment that you could use, but what would you want to measure related to that particular case? Okay, so hope that's give you a bit of an overview, guys. If you do want any other information on it, as ever, please use the discussion boards. I know there's no synchronous session for this particular week, but please, if you do want any further information, just engage by using the discussion board, and I'll answer any of your queries.